What is the treatment of trigeminal neuralgia? So I'll remember that the first line management of trigeminal neuralgia is always medical management. If you can treat your patient medically, that is the best thing that you can do. The drug of choice is going to be carbamazepine. This is the drug of choice for trigeminal neuralgia. Other medications are oxcarbazepine, phenytoin, lamotrigine, baclofen, topiramate, and gabapentin. But be very careful in clinical practice. So remember that carbamazepine, even oxcarbazepine, phenytoin, and lamotrigine all have a risk of causing Steven-Johnson syndrome as well as toxic epidermal necrolysis, which can cost significantly for your patient as well as for your own clinical practice. So what I routinely do where I was trained was we usually do a HLA testing for HLA 15 HLA-B1502. So if the patient has a positive HLA-B1502, usually we refrain from prescribing carbamazepine, phenytoin, or lamotrigine, and we try our best with gabapentin and the other medications. However, if the HLA-B1502 is negative, you can confidently start carbamazepine. It's not a very costly investigation, definitely worthwhile and definitely cheaper than an admission for a Steven-Johnson syndrome or a toxic epidermal necrolysis. So, if your patient has a medically refractory trigeminal neuralgia, the next consult will be to your neurosurgery colleagues because there is definitely a role for surgical management for patients with medically refractory trigeminal neuralgia. The surgical procedure of choice is a microvascular decompression. It has a more than 70% efficacy rate, but however, it is an invasive procedure and it requires a suboccipital craniotomy. The next other procedures are a gamma knife radiosurgery. It is less invasive, but however, it is less effective as well. The most effective surgical procedure is going to be microvascular decompression. Next is a radiofrequency thermal rhizotomy, and the other is a percutaneous balloon compression of the trigeminal ganglion. However, these two procedures have a risk of causing a trigeminal neuropathy. So basically, the pain of the patient disappears, but however, the pain is then replaced by a numbness. So there's a very high risk of injuring the trigeminal nerve and causing replacing the trigeminal neuralgia with a trigeminal neuropathy, an iatrogenic trigeminal neuropathy.